A toothache is one of the smallest disasters the body can produce. The tooth itself is tiny, but the pain is not. And given enough time, your entire universe can collapse into one glowing coordinate inside your jaw. Today, when that coordinate starts broadcasting at full volume, you can call a dentist, get an X-ray, receive anesthetic, and face a dental handpiece designed by people who apparently decided that screaming machinery belongs 6 centimeters from your brain. If infection is involved, modern medicine also has options unavailable for most of human history. Now delete all of that. You wake up tens of thousands of years ago with the same kind of tooth, the same basic pain machinery, and the same miserable pulse. There is no clinic, no modern anesthetic, no dental handpiece, no antibiotics, and no helpful internet forum where 12 strangers confidently diagnose you with 7 unrelated diseases. What can you actually do? The obvious answer is to suffer. Maybe you chew on the other side, stop eating hard food, and wait for the tooth to crack, loosen, or eventually become somebody else's archaeological problem. That feels reasonable, because we tend to imagine prehistoric medicine as a blank screen. Before laboratories, endurance. Before anatomy textbooks, guessing. Before formal dentistry, teeth were basically rocks in the mouth until the rocks failed. But archaeology has become annoyingly good at destroying simple stories, because some ancient teeth do not look like teeth that were merely endured. They look like teeth somebody interfered with. There is a reason teeth make unusually stubborn witnesses. Soft tissue disappears, spoken explanations disappear, and pain itself leaves no fossil. Teeth can remain, and a surviving tooth can preserve disease, wear, polish, microscopic scratches, and repeated contact with tools. So the archaeology of toothache works almost like digital forensics. The event is gone, the system log remains. A groove, an unusual depression, later wear, or marks that can be compared with experimental tools. None of these clues is a confession, but together they can become a case. And the story does not begin with anything resembling a drill. It begins with something considerably less dramatic, a toothpick. Grooves consistent with repeated toothpicking appear very early in the genus Homo and are especially common among Neanderthals and Paleolithic modern humans. A narrow probe, possibly wood, bone, or another material, could be repeatedly worked between teeth, eventually leaving characteristic grooves near the contact surfaces. Why? It could have been trapped food, irritated gums, discomfort, or simply habit. And that uncertainty matters. Archaeologists cannot find an ancient groove and simply announce, dentist. Cleaning between teeth is not the same thing as treating disease. The Villabruna research, for example, noted that Paleolithic toothpicking was widespread but usually not specifically associated with carious lesions. A groove tells us where something repeatedly moved. It does not automatically tell us why. Still, toothpicking establishes something important. Humans were already noticing specific places in the mouth and directing tools toward them. Irritation generates a signal, the hand investigates it, and a tool extends what the hand can do. That is not yet medical theory. It is debugging. But cleaning around a tooth is one thing. Entering the diseased tooth itself is a completely different category of behavior, and one molar from Siberia may preserve exactly that transition. Chagirskaya 64 is a lower second molar from an adult Neanderthal associated with cave deposits dated to roughly 59,000 years ago. Its chewing surface contains a large concavity that, at first glance, looks like a hole. Under closer examination, however, it becomes something stranger. Micro-CT revealed foci of deep demineralization consistent with carious lesions. The concavity extended into the pulp chamber space and, centrally, reached its floor, while its overall form did not match ordinary chewing wear. Microscopic traces on the modified surface were interpreted by the researchers as evidence that the diseased area had been deliberately manipulated while the individual was still alive. The same tooth also carries a pronounced toothpick groove close to another area of demineralization. So one molar may record 2 very different levels of intervention, working around the problem and working into it. That does not prove a formal treatment protocol, and it does not give us a Neanderthal dental profession. But it makes the old story, they simply waited for the tooth to fail, much harder to defend. Pause on that date, 59,000 years ago. This is not an early farming community full of workshops and specialist craftspeople. This is the Paleolithic, where a Neanderthal has a badly diseased molar and apparently somebody decides that the correct response is to do something to it with stone. Which would be a great story if all we had were a suspicious-looking hole. But an interpretation is not enough. If this reconstruction is right, a stone point should at least be capable of producing a comparable cavity and comparable traces. Researchers then tested the idea experimentally on human molars using comparable stone perforators. They compared different motions and examined the resulting surfaces using microscopy and micro-CT. Simple scraping was relatively poor at beginning a deep depression, while controlled manual rotation with a narrow stone point was much more effective. In the experiments, repeated rotation could progressively modify the tooth surface, with scraping motions contributing as the depression became deeper, and the resulting marks showed similarities in orientation and morphology to traces preserved on Cheghyrskaya 64. But one of the most interesting clues is actually something the archaeological tooth no longer preserves very well. Many of its traces are smoothed, which sounds inconvenient until you ask what smoothing itself might mean. Imagine scratching a line into the sole of a shoe and then continuing to wear it. Month after month, the original scratch becomes softer, less sharp and more difficult to read, not because the scratch never existed, but because the object kept functioning afterward. The researchers argue that the same general process may help explain Cheghyrskaya 64. Continued wear after the intervention could have softened or erased part of the original processing marks. The tooth had a life after the event, and that later life edited the evidence. That is why the argument does not rest on one dramatic scratch. It works more like stacking filters over the same image. Micro-CT asks what happened inside the tooth. Microscopy asks what kind of motion could have left the surviving traces. Experimental replication asks whether a stone point can create anything comparable. And later wear asks whether the altered surface continued functioning in a living mouth. Each clue alone is incomplete, but together, they narrow the alternatives. Archaeology cannot rewind the event. It can only put competing explanations in the same room and see which one survives with the fewest miracles. Now for the giant warning label. This does not mean we have recovered a Neanderthal dental manual called Root Canals for Beginners. We do not know every step of what happened, whether another person performed the intervention or self-treatment played a role, or whether every bit of altered tissue was precisely targeted rather than partly reflecting the limitations of the tool. Even the exact sequence of the overlapping modifications remains uncertain, but the larger pattern survives those uncertainties. The tooth was diseased. The altered zone corresponds to the pathology. The surviving traces are compatible with purposeful mechanical manipulation, and later wear indicates continued use. That is why the 2026 researchers interpret Cheghyrskaya 64 as evidence of intentional invasive treatment of caries, rather than random damage after burial. And that creates the deeper puzzle. How can you intervene in a disease when you do not even know what the disease is? You do not need to know what bacteria are to recognize where a problem seems to be coming from. Your nervous system does not hand you a microbiology report. It gives you a warning light with no label. There. That spot seems wrong. It hurts when I bite. Then it hurts again tomorrow. Imagine owning a machine with one flashing red light and no manual. You have no idea what is happening inside. But if touching one component makes the warning change every time, you can begin building a useful model anyway. Ancient humans did not need modern concepts of bacterial metabolism, dentine or pulp pathology. They only needed enough pattern recognition to connect pain, location, action, and result. That is the deeper reversal here. Dentistry did not have to begin with a theory of teeth. It could begin with troubleshooting. And Neanderthals were not alone. Roughly 14,000 years ago at Villabruna in northern Italy, a Homo sapiens molar preserves a different mechanical solution. Microscopic analysis found striations inside a carious cavity. Researchers compared experimental marks made using wood, bone, and small flint points, and the flint tools produced traces consistent with those observed in the archaeological tooth. The proposed action was not primarily rotation, but repeated scratching and levering inside the carious cavity while the individual was alive, possibly to remove diseased tissue, trapped material, or both. When the Villabruna study appeared in 2015, it pushed recognized treatment of caries well before the Neolithic. After the much older Cheghyrskaya case reported in 2026, Villabruna fits into an even more interesting picture. The same biological problem did not produce one universal solution. Different humans appear to have experimented with different mechanical approaches. Same bug, different patch. And later, the evidence begins to shift from isolated intervention towards something that looks more repeatable. At Mehrgarh, archaeologists identified 11 drilled molar crowns belonging to 9 adults in a Neolithic cemetery dated roughly 7,500 to 9,000 years ago. Experimental work associated with the discovery showed that flint tips could drill enamel surprisingly effectively, and the perforations have been connected with bow drill technology already used in craft production. That makes wonderfully human sense. We invent a tool for one problem, then somebody notices that another hard material might yield to the same basic trick. A tooth, unfortunately, is an inconvenient hard material because it is attached to someone who would prefer the experimental phase to go well. But Mehrgarh changes the scale of the evidence. One altered tooth can be improvisation. 11 drilled crowns belonging to 9 adults begin to look like a technique, and that is an important threshold. If a successful action can be repeated, remembered, and learned by others, it no longer has to remain one person's improvisation. At Mehrgarh, repeated drilling across multiple individuals begins to look less like a one-off act and more like a shared technique, something that can persist beyond the first person who tried it. This is not modern dentistry. No dental school, no sterilized clinic, no insurance company explaining that your molar has violated the terms of service. But it is a repeatable technique. And then the logic changes again. So far, the clearest interventions in our story have involved probing, scraping, or drilling tooth tissue. But eventually humans seem to have tried a very different idea: leave the tooth largely in place and cover the exposed problem instead. A roughly 6,500-year-old human canine from Slovenia was found with beeswax covering exposed dentine and the upper portion of a crack. Chemical analysis identified the substance as beeswax, while imaging showed that it occupied part of the worn surface and fracture. If the wax was applied while the person was alive, it may have helped reduce sensitivity or discomfort by covering the exposed area. There is only one problem: we cannot be certain it was applied during life. The researchers concluded that the beeswax was placed shortly before or shortly after death, and those two possibilities lead to completely different stories. Before death, it could represent treatment. After death, it would mean something else. So was this a prehistoric filling? Maybe. Maybe is one of the hardest working words in archaeology. The tooth survives, and the wax survives, but the patient does not explain the appointment, so researchers have to reconstruct intention from chemistry, location, wear, fractures, and alternative explanations that remain plausible. Sometimes archaeology carries us right to the door and then refuses to hand us the key. That uncertainty opens one more possibility. Perhaps ancient humans did not only intervene mechanically in teeth, perhaps they also tried to quiet the alarm itself. At El Cedrón in Spain, researchers analyzed ancient DNA preserved in Neanderthal dental calculus. One individual showed evidence of a dental abscess and a chronic gastrointestinal pathogen, while the calculus also contained evidence the researchers interpreted as possible self-medication. Among the plant material detected was poplar, which contains compounds related to salicylic acid chemistry. That creates a tempting headline: Neanderthals had aspirin. But do not write that headline. This is one individual, and the residue cannot tell us exactly why the plant was consumed, how it was prepared, or what the individual understood about its effects. The evidence is consistent with possible medicinal plant use. It is not a Neanderthal pharmacy receipt. And this is a useful warning for the entire story. We love translating ancient behavior into modern categories. A pointed stone becomes a dental drill, beeswax becomes a filling, and poplar becomes aspirin. Those comparisons can help explain function, but they can also quietly smuggle in things the evidence does not contain, such as formal diagnosis, standardized training, dosage, specialization, or medical theory. Prehistoric people did not need to be modern dentists wearing fur for their behavior to be extraordinary. They only needed to pay attention. One tooth behaves differently. One area repeatedly seems to be the source of trouble, and touching, cleaning, or altering that area changes something that can be remembered. In some cases, another human may even have been involved, which adds one more ingredient: trust. Allowing another member of your group to approach an already painful tooth while holding a piece of stone may be an early version of, "I know how this looks, just trust me." So how did ancient humans deal with severe tooth pain before dentists existed? There was no single prehistoric solution. Some people almost certainly endured it, while toothpicking offered a way to clean or probe troublesome spaces, although toothpick marks alone cannot prove medical treatment. At Chagirskaya, a roughly 59,000-year-old Neanderthal molar preserves evidence researchers interpret as deliberate invasive intervention in carious lesions. At Villabruna, Homo sapiens appear to have scraped and levered within diseased tissue. And at Mehrgarh, drilled molars across multiple adults suggest a repeatable technique rather than a single improvisation. In Slovenia, beeswax may have covered a sensitive damaged tooth, though the timing remains uncertain, while El Cedrón provides a tantalizing but limited clue that a Neanderthal with health problems may have consumed plants with medicinal properties. That answers the central question, but the teeth have been telling us a larger story all along. Modern medicine usually runs in one direction: identify the disease, understand the mechanism, and choose the treatment. But knowledge does not always begin with understanding. Sometimes it begins with feedback. The body effectively says, "There," and the hand asks, "This?" Something changes. The result becomes memory. Memory becomes technique, and technique can move from one pair of hands to another long before anyone understands the invisible biology underneath it. That is not ignorance accidentally wandering into medicine. It is one of the ways medicine can begin. We like to imagine human progress as a clean staircase in which we first understand and then act. But history is usually messier than that. Sometimes we learn what works before we know why it works. We recognize a signal before we understand the system generating it, and we build a crude solution before we possess the theory that explains it. 59,000 years ago, somebody encountered a diseased tooth. They could not see bacteria, name the pathology, or consult a textbook explaining what the pain meant, but they could locate the problem, observe it, and try something. Perhaps that is the oldest thread running through this entire story. Long before we understood the body, we had already discovered one of medicine's oldest ideas. Pain was not only something to endure, it could also be a clue that something inside us might be changed. If you like stories where one tiny piece of evidence can rearrange the entire human past, subscribe to Oddplain. We'll keep digging into the strange problems our ancestors refused to leave alone.